Udani sir.
Yeah, hi.
Good afternoon, sir.
Good afternoon.
Hello, dear friends, students, and good evening, Ambekar sir, Chokhani sir, Udani sir. Let's start with our session today. We have the first 1 hour where we'll be discussing a very commonly asked exam question, that is approach to a child with seizure on day 2 of life. And in the second half, we'll be having a case presentation by Dr. Ayushi, which will be again an exam neurology case. So Dr. Sonali, Dr. Saurodeep, Dr. Ayushi and Dr. Poonam, you all will be the volunteers for discussion. Please keep your videos on. Rest of you all can answer all the questions in the chat box, please. Dr. Sonali, Saurodeep, have you all joined? Ayushi, Poonam? Anyone? Dr. Sonali, you are here. Please keep your video on.
Looks like they've chickened out.
Dr. Mona, you are also there. I can see you online. So till you have to go for your duty, even you can volunteer, keep your video on and answer the questions. Yeah, thank you, Dr. Mona Lisa. And Sonali also. I think, sir, we'll start.
Sure.
Thank you, sir.
So you want me to take over?
Yes, sir. Yes, sir.
Okay. So good evening, everybody. I think the first part of this session is essentially the approach to neonatal seizures. It's mentioned day 2, but I think we should sort of generally talk about the approach to neonatal seizures anyway, in any day actually, and then maybe focus a little bit on day 2. So let's, instead of me telling you what to do, I would like you to tell me about how you would approach the question. So, Sonali, can you go ahead? You're mute.
Sir, neonate presenting with seizure on day 1, I would suspect for a birth asphyxia, HI, and if it comes after the day on day 2, day 3, it mostly a metabolic disorder like a hypocalcemia, hypoglycemia. I would want to ask the history for whether the child was a small for gestation age, large for gestation age, any feeding issues. Then after on what day of life the seizure has occurred, that will bring us to the etiology. If it is occurring at a late onset, then we would suspect sepsis or late
Fair
onset
enough.
sepsis.
So you're talking about the basically the etiology, in the sense looking at the day of life and giving the etiology. How do you normally approach seizures in any age group? Let's just, so I'm not giving you exactly how you speak, how you would write in this particular thing, but let's just understand how you normally approach seizures.
We'll first classify into whether it is a generalized focal or.
You have any other ideas, Monali?
Sir, if there is the history of day 2 seizure, then I will see the seizure type, and first I will rule out the main common causes like hypoglycemia. For the approach, I will common causes like hypoglycemia. If there is hypoglycemia, then I will give D10. Otherwise, if there is no system to see whether to monitor glucose, I'll also give D10 injection, and I will think about hypocalcemia, and also according to the history, ANC history and birth history, I will think of other causes. In
Okay.
NCST, yes, sir.
Let's stop there. I think the first question, any of the other people have come? Ayushi and Sauradeep and all?
Dr. Rajiv is also there, sir. Dr. Rajiv will also be there.
Yes,
Yeah,
sir.
could you put
Good
on your
evening, sir.
video? Yes, please put on your video and just talk.
Good evening, sir.
Yeah, good evening.
Sir, I would like to approach the case of neonatal seizure. First, I will ensure temperature, airway, breathing, and circulation, first of all. Then, I mean thermoneutral temperature, airway, breathing, and circulation. So that simultaneously, I'd like to take a short history as to what has caused this neonatal seizure, and also take blood for metabolic for hypoglycemia or hypocalcemia.
So what you're saying is essentially you're approaching it from a purely management perspective, correct?
Yes, sir.
Okay. Ayushi, you have any other ideas?
Sir, I missed the history part, but if
There's
neonate
no
is
history part. It's a approach to a neonate with seizures on day 2. So how would you approach? That's all it says.
so the first thing, the most common cause is HIE if the patient has not received enough oxygen. So I'll attach the child to the oxygen. Then second thing is hypoglycemia. I'll make sure the child is HGT is normal and I'll correct the hypoglycemia. Then hypocalcemia part I'll correct. Then hypomagnesemia.
Okay, fine. This is the first thing you should always understand approach to seizures is it a seizure? Okay, who identifies seizures generally in the NICU? Usually it's the nurses who are on call. They see some movements or whatever it is, and they tell the resident that there's a seizure. Similarly, a junior resident might see some movements and decides a seizure. So the worst thing to do is to jump into the fray and say this is a seizure, and sort of, because many movements in the newborn, many other types of things can occur in the newborn, which are clearly not seizures. So can you tell me something about that? What are neonatal seizures, which are seizures, and what are neonatal episodes, which are not seizures? So non-epileptic events in the newborn and epileptic events. And this applies to any day. It doesn't matter day 2 or day 3 or day 4. So I'm not saying that you do not do all this, temperature, TPR, this, that, all that, but you have to be certain, at least, otherwise you'll be over treating, right? That's the problem. So how do you decide? So what type of seizures are definitely, or what type of episodes are definitely epileptic or seizures, and what type you think are usually not? That means you must know the different types of seizures in the newborn.
So if it's a
Anybody
generalized
can-
tonic-clonic seizure, it's definitely a seizure.
Anybody else has any answers on that?
Sir, if it is epileptic seizure, like the seizure always associated with easy findings, like clonic seizure, if there is movement of clonic movement of body parts, and if there is uprolling of eyeball, like subtle seizure, these seizures are mostly associated with easy findings, and we have to treat it.
Okay, I think we have to stop over there. You have any other ideas, Monali? No, not Monali.
There are some
Sorry,
in the chat
Sonali.
box saying jitteriness and myoclonus in the chat box.
Very good, very good. So the first thing is you've got to look at the non-epileptic phenomena. Somebody said myoclonus. What kind of myoclonus occurs in the newborn, and how does you? I mean, suppose somebody in the nurse tells you this patient had a few jerks. What questions would you ask? So what kind of myoclonus is non-epileptic in the newborn?
Chronic infancy.
One minute. Sorry, one person, please. Okay, somebody's answered. Why don't you put a Kirti, somebody said sleep myoclonus. Why don't you put on your video and answer that question? Kirti. How do you differentiate sleep myoclonus from other types of myoclonic? So can you just tell us?
Sir, benign sleep myoclonus is provoked by stimulus, and it will get relieved by restraints. But if it is a true seizure, we there won't be any history like provoked by stimulus or restraint by.
No. You're talking about, you're not talking about sleep myoclonus. Essentially, sleep myoclonus occurs in babies in sleep in the first few days of life, maybe up to a week, and occurs only in sleep. You can get jerks like this, clonic jerks. You may get, either in the upper limbs, lower limbs. You might get going from one side to the other. You might get it together. And as soon as you wake up the baby, or whenever the baby wakes up, you don't see it. So this is a very common reason why people are treating neonatal seizures. So I'm not saying that day 2 seizure is common. So this is a non-epileptic event which usually comes at the end of the first week. So, but these are one of the non-epileptic. Suppose, let's say another example, that you have a patient who had a hypoxic ischemic problem or some asphyxia or some didn't cry at birth. The child comes in and he is a little encephalopathic. He is a little lethargic and all that. Now, what kind of episodes in these are not really epileptic? So, because basically you must understand one thing. I think one of you said that the EEG should be done. And the answer is yes, the EEG should be done, but often it is not available. So how do you decide? So if you, when you're writing the theory paper, you should say that ideally seizures should be those with a characteristic EEG signature. But in our country, there are not many people who can read a EEG, and especially in the NICU. And therefore, this is in a situation where like this, what kind of seizures are definitely seizures, only looking at them, and what are not. So you should know the different types of seizures. Correct?
Mm.
So one is the most common seizure is, which is definitely epileptic, is focal or multifocal clonic. So what is a clonic seizure? Rhythmic slow jerks, which has a fast and a slow component. It can be here, it can be here. Somebody said generalized. Seizures are never generalized in the newborn period, because seizures need myelination for generalization. And we don't have that in the newborn period. So you have either focal or multifocal clonic, and these are the ones which clearly have an EEG signature in most cases. Sometimes, of course, it could be a sleep myoclonus, which looks something like a clonic seizure, except there is 1 or 2 times rather than continuous. But this is, I mean, a non-epileptic event which can look like that. But usually, if you have a situation where this focal, clonic, or multifocal, all the rest, for example, tonic, somebody said tonic seizures, bilateral stiffening of the limbs, or one side stiffening of the limbs. So how do they correlate? So if it is one side correlation of the limbs, yes, these are often associated with epileptic discharges and are probably epileptic, but not as frequently as the first group. However, if you have generalized like this stiffening and arching and all this kind of thing, these are not really epileptic in the majority of cases. These are just what are called release phenomena. So you, especially in very severely insulted newborns, if you have brain injury due to severe hypoxia or something of that sort, the cortex gets fired and you get these kind of episodes. Subtle seizures, somebody said. Subtle seizures, yes, can be, but things like pedaling and swimming movements and eye movements, ocular movements, very often do not have an EEG signature. And they also are seen in patients who have severe encephalopathy. So to make a long story short, just to tell you, because many of you don't know this, the majority of movements in the newborn period, it has been shown, confuse people. Many times they are normal movements. Many times they are benign movements like sleep myoclonus or jitteriness. Jitteriness, by the way, is a kind of a tremor. That comes on with stimulus and you can restrain it, like I think Rajiv was saying. There is jitteriness. So there is, so these are some of the things which can confuse you. And when you actually look at the, there are lots of data which suggests that doctors get confused, nurses get confused. And when you do EEGs on these patients, half of them don't even have seizures, maybe more than half. So it's very important that the first thing in your picture you must write. The first thing I will check, of course, I'm not saying you do not check the vitals and all that, but don't suppose you're called to and asked to say what this patient had a seizure, what do we do? Don't start just rushing. And first thing, of course, you do all your checking of glucose and all that, of course, but keep it in your mind that it may not be a seizure at all. Okay. Now, second thing, so I told you the different types of seizures with the newborn. There are no generalized seizures. The last seizure which is there, I would say myoclonic actual seizures. So you get myoclonic seizures, jerks, or that kind of thing in the fully awake state. That very often means it's a bad disease, like a metabolic disease. So this is the way you approach it. Is it definitely a seizure? Is it a non-epileptic event? This should be going through your mind. So now you obviously go to the third thing, that if this is really a seizure, you come to the conclusion, what is the cause of the seizure? So can somebody tell me about how do you approach an etiology of seizures? First of all, what type of seizures? What are the usual causes? In the sense, I'm not talking about different causes, but are these symptomatic seizures or are they epilepsy? Can somebody tell me, or can they be both?
They can be both, sir.
Okay, so give me an example of epilepsy, for example.
Ohtahara syndrome, they can present in neonatal.
Yeah, so I
period.
think you're right. So you may have epileptic encephalopathies. Anything else which can come to that at that age?
Sir, inborn error of metabolism.
Okay, so all those things, inborn error of metabolism generally could be a symptomatic seizure. You understand? So it may be also, could be epilepsy also, but the epilepsies in the newborn are only 10%. Usually the symptomatic seizures.
Right.
What is the meaning of symptomatic seizures, Sonali? What do you mean by acute symptomatic seizures or acute provoked seizures, as opposed to acute unprovoked or unprovoked seizures, or acute unprovoked seizures? And how do you tell the difference?
The cause is not known for the first episode. What is the cause of the seizure?
No. That's why I'm saying I think there's a lot of confusion. Seizures are not necessarily epilepsy. The seizures can be anybody who undergoes, say, hypoglycemia, a newborn or an adult can have a seizure. But epilepsy means there's no reason. It's unprovoked. So in older children, majority of seizures which come into your thing are epileptic seizures. The same epilepsy, in the sense there's going to be a chance of a second or third or fourth seizure. But in the newborn period, majority of them are symptomatic, means they are caused by something which will give rise to seizures in anybody. So for example, now you can tell me the causes, and therefore when do they present, and how do you pick it up from your history? What are the risk factors and all that? So I think over here we'll go through each one. Each person give me one particular. So let's say, Sonali, you talk about hypoxic ischemic encephalopathy. Tell me what are the risk factors, what you will ask in the history, and what you will, when do they present necessarily? What is the type of seizures they come with, how episodes they come with, and most important, how would you treat them? Treatment will come later. Let's just talk about hypoxic ischemic encephalopathy, the risk factors. In the history, or how will you ask? Suppose the baby lands up in your hospital with the seizures on the first day of life or second day of life. How will you approach?
So whether the baby is lethargic or not, whether feeding has been initiated within first few hours of life, and whether this will suggest a neonatal encephalopathy for this child and associated with seizures or not. So,
Correct. So
The
you're
first
absolutely
question
correct.
will be cried immediately after
No,
birth.
let her finish. Let her finish. Yeah.
um,
So what is this definition of neonatal encephalopathy?
um,
In the sense,
the,
how do
the
you recognize it? How are the
the
different
child,
ways of it?
child is usually lethargic, not responding to the, not giving proper stimulus, not giving proper
Not
response to the
responding,
stimulus,
not correct. Then
and not feeding well means the feeding is not established in the first few hours of life, and also they can present with seizures in the first day one of life.
is she hypotonic or somebody mentioned baby is hypertonic, and is there hypotonia or hypertonia?
Sir, the tone in the mild stage will be hypertonic, and as the Sana staging stage 2 and 3, there is flaccidity. The tone is flaccid in that stages.
Yeah, so in the first stage, you might get a little, it's not, I mean, usually most babies who are significantly encephalopathic to have seizures, usually patients will be hypotonic. Okay. A little bit of irritability and hyper excitability, which occurs in mild staging of Sarnat's HIE, is not something which will usually come with seizures. I mean, it may, but it usually stage 2 onwards is seizures. So I think that's important. When you have some usually hypotonia, the first thing is feeding difficulty, difficulty in sucking, hypotonia, lethargy, sleeping a lot, that kind of thing. So you have an encephalopathy, and seizures are when you have definitely a significant encephalopathy. Correct?
Yes, sir.
Okay. What about anything else besides, and what is the history, the risk factors? How do you diagnose from the history that when you haven't, the baby has not been born in your hospital, it's come from outside. How do you diagnose that? Somebody, I think Ayushi said about not crying at birth.
APGAR scoring at the time of birth, crying, any difficulty at the time of delivery, prolonged delivery, or
So
yeah.
before that?
ANC history will ask if mother had any.
No. I'm talking of the many HIE occurs in the last couple of day or two, or maybe before delivery. So how does it first? What is the first thing of inkling of that you might get in the acute and in the just in the before delivery? What kind of
Leaking PV?
no?
Decrease, quick decrease
Nuchal
movement,
cord,
fetal movements.
nuchal cord. Okay, you may get changes in heart rate. You may, if you're monitoring it,
Biophysical profile.
you may have a nuchal cord around the neck, that kind of thing. You may have meconium stain like that's important. So those are the things which tell you that something is going on before the delivery, and you rush and do whatever you have to do to cesarean or whatever. And the baby is born, and your ABGAs are low, but the ABGAS problem is you may not have ABGAS. You may only have this thing about not crying at birth. So what does not crying at birth actually mean? If you do not have encephalopathy later, it means nothing, correct? Because that's just many babies don't cry immediately. They take a few seconds or maybe half a minute to cry, and then they are fine. So it has to be a significant amount of thing. Okay. Let's go to the next etiology.
Hypoglycemia.
Okay, so tell us about hypoglycemia. When does it occur? What are the risk factors? And how do you, what happens?
So risk factors are baby born to diabetic
When does it
mothers.
occur? Before we go to HIE, what day of life is it usually? Sonali?
Day one of life, sir.
Day one of life, if it is significant, but it can occur after the first 24
Mm.
hours.
Yes.
Because if it is not severe enough, you might get, because on the second day, what happens usually in HIE? You get secondary brain injury. Na? That's what you're trying to
Yes.
do when you're giving hypothermia.
Yeah.
The primary brain injury, which occurs at the time of hypoxia, you can't do much about. The neurons are dead. But the secondary brain injury comes on 24 to 48 hours later. You may get swelling, you may get excitotoxic injury, all sorts of things. free radicals and all those things I'm sure all of you have read about. But these things cause these problems in the second, third, fourth day. Second, third day usually, and that time you might get a seizure also. Of course, the patient will be encephalopathic in the first day, but the seizures might come on day 2. So day 1 or 2, one more than 2, but those are important things.
Yes.
Okay. Now the hypoglycemia. Tell us, when does that come and what are the risk factors? Ayushi, you were saying.
So risk factors is babies born to mother with diabetes and small for gestational age or large for gestational age children. And yeah, risk factors are mainly these. And they
Anything
come.
else? Anything else? So large for gestational age and diabetes, of course. Usually these are patients appear when? On day 2 or day 1?
They generally present by day 1. Day 1.
Day 1.
If
Correct.
diabetic
So they are
mother.
not, they are, yeah. And
Preterm also,
basically,
sir. Preterm.
yeah, late preterms and all. So very many, we talk about the birth weight. I'm talking of the IDMs, or the large gestation age. You don't have to have obvious diabetes. You may be this large gestation and still be at risk for hypoglycemia, but basically most of them are IDMs. And this is early, and these patients come on the first few hours of life. Many are asymptomatic. So if you're, unless they are really being, nobody is monitoring and nobody knows about the diabetes and all that, then of course they may throw a seizure or something. But usually, well, the second one is low birth weight. Very important. And can you tell me a little bit about low birth weight? What do you consider low birth weight?
Small for gestational is less than 2.5 kg is low birth weight for a child. And very low birth weight is less than 2 and extremely is less than 1.5 kgs.
Okay. So that's important thing. When do they present usually?
Day 2 to day 3,
Okay,
later
day
than
2 to
day
day
1
3.
after 24 hours.
So the history is what in those kind of babies?
Not taking feed appropriately, not
Okay, so very often there's the first day they may be looking quite vigorous and all that, and then they start crying a lot because they are hungry, they can't feed or whatever it is, and they go into a, feeding is not done for various reasons. People say, give them breast milk only, abhi aayega, nahi aayega, etc. And in that situation, what may happen is, because if you insist on, you may develop low glucose if your stores are not there, as you all know. And that happens on day 2, maybe end of day 1, day 2, maybe sometimes even day 3, and sometimes even later than that. But most of the time it's day 2. That's one. Important thing is patients who are stressed. That is important to realize. You must mention this. So low birth weights, when there is a stress, so there's a mild fetal distress, there's a some little bit of stress. HI is one of the common causes of secondary hypoglycemia. That you must mention as an important reason. So he didn't cry at birth, he had to be resuscitated a little bit, then he was okay, and then second day he had a seizure, and that is the time you might get hypoglycemia, which comes along with the mild HI. That's secondary secondary thing. And last one, which not the least risk factor, is when do babies not feed? Why does the baby not feed? So one is, of course, problems with the baby, and second is problem with the mother. So I said problem with the baby, maybe there was a mild fetal distress, maybe there was preeclampsia, whatever it is, and then that causes a little bit of hypoglycemia on second day. But what about the mother?
Postpartum depression, she can be in.
No, postpartum depression on second day only. No. What about anybody else wants to answer? Monali, sorry. I only know Monali, Ayushi, and Sonali. Anybody else is there? I don't see anybody else's face.
Sir, low milk output in mother. Or
correct. And no low milk output along with
starvation and breast factors like flat nipple, so that there will be difficulty in sucking for the baby.
Yeah, that's fine. I'm saying maternal factor in the sense, when do mothers, when they're sedated, when they come out of anesthesia. So one of the important risk factors is LSCS. Baby, the mother comes out, there's pain, there's sedation. The first 1 or 2 days you may not feed, and then you insist on, give nothing because you might develop. So that is the time when the highest risk occurs. So if you have a low birth weight, that is a typical story. Low birth weight, mild fetal distress, comes on second day, has LSCS because of whatever reason. Mother is not feeding. Nurse says you must feed only breast milk. Nothing wrong with that. But the problem is you should use breast milk from other, don't starve the baby, as you all know. You have to feed the baby in the first, maybe in the first 2 hours for low birth weights. And those who are full terms and have even more than 2.5 kilos in the first 6 hours. So you must have all that. You put the baby on the, what's it called? Crawl, breast crawl, and all sorts of things. So those are important things to be done. And that's why starvation is such a thing. You must avoid that at any cost. How else will you avoid it in low birth weights? Sonali? Or Poonam? Poonam has put she wants to answer.
So top feeding.
Yeah, that's fine.
Top
But if the patient is in your ICU, how will you handle it?
So IV
low-
foods. IV
अरे
foods.
क्या बात करती है? If he's in your ICU or if he's in the ward, you start monitoring glucose for the first 48 hours.
Frequent glucose.
That is the most important thing. So you must say that anybody who is at risk for hypoglycemia, IDMs or low birth weights or cesareans or what have you, first 48, 72 hours, you must monitor glucose if you can. Then you can say, I'm in the village and I can't do that. That's a different matter. But important that when you have the facilities, you must monitor glucose. If the baby is with the mother, you don't want to keep pricking it, then you keep checking the baby. But somehow you got to make sure the baby is feeding and make sure of all that. Okay. Anything else besides these two important causes? Anything else?
So meningitis.
Not talking of day 2. Somebody else? Poonam? What happened to
hypocalcemia?
Okay, so what are the types of hypocalcemia which occur on the second day?
We check for serum calcium and any calcium.
There's early onset hypocalcemia and late onset hypocalcemia.
Okay.
Okay, late onset hypocalcemia doesn't really occur on the second day. Usually it occurs little later because of it's maybe in the latter part of the month or maybe in the first. It is basically because of vitamin D deficiency and stuff like that. On the other hand, cow's milk and basically some giving cow's milk and there's vitamin D deficiency and that kind of causes hypocalcemia and the late onset hypocalcemia. That's not something which you see on day 2. Early onset hypocalcemia usually secondary. Secondary to what? It could be again fetal distress, HIE, etc., etc., etc. So of course you must check it and you must treat it if it is significantly low. Any other causes anybody can think of? Any questions you have? Please go ahead.
Hypomagnesemia
will present in day 2, sir?
Sorry.
Sir, will hypomagnesemia present in day 2?
Hypomagnesemia.
Yeah, it could, but hypomagnesemia is extremely unusual. So when you're talking about causes, you should have a HI is of course the most common. Metabolic things like hypoglycemia are most common. Hypocalcemia is less common. Hypomagnesemia is very, very uncommon. Okay, because it's usually something which is a genetic thing and all that, and it can occur. But I've seen 2 cases in my entire life so far who come with hypomagnesemia. I don't know if Chokhani or somebody wants to say anything more on that, but I have really in my, so I'm not saying you should not do it, but it's a very unusual thing. Any other important causes which can happen in say preterms?
Sepsis and premature.
Correct. So most important is ventricular hemorrhage, intraventricular hemorrhage. Those are important causes, and therefore you should always keep that in mind in very young babies. So preterms, for example, late preterms, more chances of hypoglycemia, early preterm maybe more chances of especially if they are AGA, more chances of intraventricular hemorrhage. I mean, the chances of hypoglycemia will be less over there, but they also are very prone to that. So basically, I think these are the three important. What about infections?
Torch infection.
Early onset sepsis and late onset sepsis. The early onset sepsis in children.
Ayush, somebody else answer, please.
So Poonam is
Rajiv?
now unmuted. Poonam can
Okay,
answer.
Poonam.
Yeah, so sir, on day of life, too, early onset sepsis can be a cause of hypoglycemia. So we
Correct,
could rule out
correct.
torch infection, CMV infection, rubella, herpes, or we could like find out any cause given to the mother. Like if mother had any intrauterine infection, mother had a history of fever, or any history of chorioamnionitis.
So any sepsis syndrome, it could be a early bacterial sepsis, it could be a sepsis syndrome caused by late, perinatal infections which have come up or whatever it is, or maybe something else. But then yes, so that obviously is a high risk for hypoglycemia. But sepsis by itself causing seizures is not common by itself. So if you have a patient who has sepsis and has seizures, what should you definitely do?
HGT, hypoglycemia, we should rule out.
वो तो बोला ना एक बार. Anything else?
We should rule out
CSF
hypoxia.
studies.
We should
CSF studies. CSF studies. So every
CSF
baby who
studies.
has seizures, especially
Infection.
there's no obvious cause, must get a CSF study. Okay, I think that's an important thing. Okay, but meningitis usually is it a common? I mean, it can come with sepsis, which is very early, but meningitis by itself comes a bit later. That's usually seen, in the maybe the end of the first week or something like that. So especially the babies in the ICU and nosocomial stuff and all. So that alone meningitis without much of that is something which can obviously give rise to seizures. Anything else? What about inborn errors of metabolism? All of you have talked about
Sir,
that.
mostly in case of inborn error of metabolism, initial first 1 to 2 days the baby was fine. After that, baby starts lethargy, poor feeding, and also seizure sometimes associated with hypoglycemia, and also in sometimes associated with hepatomegaly. In that
Correct.
case, we can suspect IAM. And also
Yeah.
there is a history of consanguineous marriage or previous fetal death or previous child
Very
death.
good. Very good. So inborn errors of metabolism you would think of usually after the introduction of feeding. Correct? And that is the time when protein loads occur, and that's why you might develop some issues, which are the common ones which come at this age.
Glycogen storage disorder
Galactosemia.
and
Galactosemia.
galactosemia
Yeah.
or
Organic acid.
Hereditary factors in children.
Yeah, so things like organic acid, maple syrup urine disease, sometimes urea cycle, all these things can come in the first few days of life, but usually after introduction of. There are a couple of them who come without history of feeding. Again, another inborn error of metabolism. Two recent, one is the old one, but the one which is recently described, and that is not something which is common, but I'm just saying. So one is, of course, what comes on the first day, first or second day? Metabolic disorder coming on the first or second day. Pyridoxine, absolutely. So it could be prenatal. You might come out seizing, or it might come out in the first couple of days. It's not that you have to be on the first day. You might miss it on the first day. And these kids are very irritable. They're having multifocal seizures, they're crying, and they're having crying along with the multifocal. Very often that happens. And that's why, obviously, you must think of this. And of course, there's another active pyridoxine, that is pyridoxal phosphate, is very rare, and that can happen also. And so both these things can occur. So you must think of metabolic conditions like pyridoxine-related seizures early in the first 2 days of life, unlike the other metabolic things which come a little later. Anything else?
Sir, to suspect pyridoxine deficiency, can you think like if the seizure is refractory to anti-epileptic drugs, and
No,
we
no, no,
have ruled out.
we'll come out to the management. I'm talking of the approach. Approach means what? It's not just, you must also mention about what are the etiologies in brief. So when you're writing your thing, write briefly about, is it a seizure, the what type of seizure, and then a little about the etiology, and then you come to management. So management obviously will be different. I'm not saying all these things are done, but you must know the theory of all these things. Nah? So when you approach a seizure, these are some of the questions which you'll have to put down in your notes. If it's a long, I mean, this is a short note or a long, note. I don't know. How does it normally come?
So every question in BNB is 5 marks question. So it can come in a 5 marks question pattern.
Yeah, so it depends. If it's such a short 5-mark question, then probably it won't get such an important thing. You want to give such a long answer. But I'm just, because we are discussing it, so I just thought we'd discuss everything. And now, so we've discussed about any other etiologies which I've forgotten.
Sir, ischemic stroke.
Yes, very good. Ischemic stroke is extremely important. So tell me something about strokes, which. Sorry, who's that? Rachna Redkar, please mute yourself. So basically, I think, tell us about ischemic stroke, Rajiv.
Sir, here mental status will remain preserved.
Yes,
case
very
of
good.
ischemic stroke. And secondly, usually there is no asymmetry in the motor examination, the acute phase.
Very good. Why not?
Uh,
You're saying very often it comes with minimal or no encephalopathy. You get seizures, which may come on, anytime in the first 2-3 days. And basically, it doesn't have to be a focal, though it very often is a focal seizure. But it could be multifocal also, and there's no asymmetry. Usually it's a focal seizure, but there's no asymmetry of movement. Can you tell me why? I mean, not that it's important in your notes, but in your answer, but it's important to know why.
Sir, because it involves part of the.
No, it's not that. Because when you're born, newborn period, your proximal limbs are controlled bilaterally by either right or left. So you don't see much of asymmetry. Your hand function and your foot function, that function is not there at that age. That's why very often neonatal strokes, you find the asymmetry or all that coming up as preferential hand use within the first year of life. So when they start using their hands at 6 months or 5 months or whatever it is, you realize that he's not holding one hand or he's fisted like this and all. So you realize the thing afterwards. And very often in patients, if you are, of course, this is not for with those with neonatal seizures, but if you see a patient with a stroke which has been incidentally discovered at the age of 6 months, and you know it's a perinatal stroke, probably it occurred before. So 2/3 of all perinatal strokes occur actually before birth. It's only about a small number, 1/3 or so, maybe less than that, which occur at birth with neonatal seizures. It's important to know. Anything else we've forgotten? So now we come to the epilepsies. Okay, and what is the most common and benign epilepsy you must know about? Of course, that doesn't come on day 2. It comes a little later on day 4, 5.
Benign idiopathic neonatal convulsions.
Absolutely correct. Now it is called self-limiting familial or non-familial neonatal seizures or neonatal seizures. This is a type of epilepsy. It may persist, but it usually comes when. Just tell us about it a little bit. Whoever answer that question.
It comes on 5th day of life, and it is assumed to be because of low levels of zinc in CSF.
Yeah, but that has been sort of not really confirmed. Now, most of them appear to be because of, potassium channels kind of thing. The zinc thing is, I know it's been talked a lot about in the past, but I don't think it's been confirmed. So really, if it's a familiar thing, there's no question. It is because of channels, potassium channel. It's a potassium channelopathy. But even the non-familiar one, because the non-familiar one is just a question of history, and you may not know somebody in the family had it at birth and never had it again. So it's very difficult to say. But these were called fifth day fits, and they come in. How do they come? How do they present? No encephalopathy. And they get repeated seizures, they get a lot of cluster of seizures, which are focal and multifocal or whatever, chronic, and then they sort of, over a couple of days, they get sort of controlled, and that's it. And maybe some of them will have seizures later, but most of them don't go beyond the newborn period. Anything else? Any other types of epilepsies? So all this epileptic encephalopathies, otohara, all those that already mentioned. I think that's about it. And malformations, brain malformations. If you have, rarely they can present in the newborn period. Usually not in the first 2 days, but little later. That's also.
Best syndrome, can it present in neonatal period in the first?
Yes, it can. Epileptic spasms can. That's why, but it's extremely rare. Extremely rare. So I would not say first, because these are very rare conditions. So usually tonic seizures can occur, which can look like West syndrome, because it's just a matter of stiffening, which occurs for a little longer time. And that's very often a bad epilepsy, something like Otohara syndrome and all this. Anyway, let's forget about the etiology. Now let's come to just the management. Last 15 minutes we have for management, or 10 minutes. So somebody else now, anybody else want to take it up? Nobody there?
Sir, for management, first we'll
Rajesh, anybody can ask, we can pick up and we ask them to.
Sauradip, you are volunteered for this one, na?
Has he come? He's not here.
I can see Sauradip Maiti.
Yes, sir. I'm just trying to find my tab and earphone.
We can hear you fine. So tell us how you would approach the management. This patient comes to you, not comes to you, but is in the ICU. You've been called by the nurse. You are definitely in a seizure. How are you going to, what are you going to do?
Sir, first, as in every emergency, we'll proceed with stabilizing airway, then check oxygen saturation and put an IV cannula, correct the volume status. Then we'll check the RBS, I mean random blood sugar and calcium at the same time. Give dextrose bolus and start on calcium gluconate if hypoglycemic or hypocalcemic. Then
So what, you'll wait for the report to come, or how will you do it?
Sir, RBS can be checked bedside only with.
You can't check the calcium, no?
Yeah.
So let's not rush and give calcium.
Yeah.
So
And
suppose you do the RBS and you get how will you give it? I don't know I've forgotten the doses. Rajesh, you better help me in this. But tell me, how do you do it?
Symptomatic children, 40 less than 45 mg per DL is the indication for giving IV dextrose bolus 2 ml per kg. Then if still not seizure,
Of 10%, right? Of 10%.
10%, 10%.
You must mention that, please.
And
then what do you do after that?
Yeah, so seizure is still if seizure is still persisting,
No, I mean, after you, what happens after you give the bolus? What happens? You stop the glucose, you continue the glucose, what?
Yeah, sir, we continue the glucose at a glucose infusion rate of 6 to 8 ml per kg per.
You must mention all this, yeah, okay.
Yeah.
So you continue the glucose, okay. Then go on.
Then we start if the seizures are still persisting.
Suppose you could, 1 minute, before that, suppose you could not do the glucose, is not available or something, and you anyway you give your thing, and then he continues seize, what would you do next?
Sir, we'll give the first drug of choice for neonatal seizure, phenobarbital, at 20 ml, 20 mg per kg over 15 to 20 minutes. Then we'll wait for 5 minutes to 10 minutes to see if the seizure has stopped. Then we can go forward with another.
1 minute. How are you going to give you a phenobarb? You're talking about say a baby is 2 kilos and you give 40 milligrams of phenobarb, and what is 1 ml of phenobarb in the vial? How much does it contain? Anybody knows that?
200
Correct. Somebody
milligram per
mentioned
ml.
correct. So Nikhil had answered correctly. 200 milligrams per ml. So you want to give 40, 45, maybe 50 milligrams to this patient, which means you're going to give 0.25 ml. And that 0.25 ml you're going to give over how much time? 20 minutes.
Sir, we'll dilute in 20 ml NS and then give.
I see. I think it's a bit too much dilution. I think it's a bit too slow, but I don't know. What do you all think, Rajesh, or anybody else? Because we generally, I mean, it's one thing to talk about 20 minutes. I understand that we could go slow, but 20 minutes is a long time, and to allow a
Yeah,
baby
in
to see,
neonates, 20 minutes is very long. So in
yeah,
neonates,
to
it could be
seize,
just, yeah.
yeah. Within 5 minutes, 6 minutes or so, you dilute it, 1 or 2 times for what it is, and maybe 2 ml or something of that. So then slowly give it over. Of course, keeping a watch on the respiration and stuff like that. But frankly speaking, I don't know. You better check this whether 20 minutes sounds like a very long time to allow a newborn to seize. You see, you understand, in older patients, we always give benzodiazepines. And generally we don't give benzodiazepines as the first drug in newborns. So, what about levetiracetam? Anybody has any ideas on that?
Sir, if patient does not respond to phenobarbital after 2 doses, we generally load the patient with second drug.
Why not the first drug? So, anybody heard of the NeoLev study? So remember, he's absolutely right. Phenobarb has been shown to be much more effective than levetiracetam, almost, and so I think I agree with you, phenobarb. And if what is the next drug of choice? You could give what else besides, if it is not, suppose 20 milligram doesn't work, what do you do?
Sir, we'll give phenytoin 20 mg per kg.
Okay.
First,
Some people give more phenobarb.
Sir, we give 20 mg per kg phenobarb. If seizure not subsided, then we'll give another loading of 10 mg per kg, and we can go up to 40 mg per kg. And if
Correct.
not
Now,
subsided,
yeah, you're absolutely right. This is all given in American textbooks. The only problem with that is that for some reason, be a little careful. I'm not saying you don't use those 30 milligram per kilo, but there's a very high chance of this level going up to much, much higher than what you want. So you don't want to, the target level should be around 40, 50, but sometimes, it goes to 80, 90, it becomes a problem. So be a little bit careful. Of course, you must, in your notes, you can mention that you can go up to 30, at least 10 milligram per kilo more, even up to 20 milligram more. But you have to be careful about, this. And these babies then become very limp and they don't, it's very difficult to. So unless you have, and you must do levels if that happens. Okay, so if that is, so there's another alternative is you give a second drug and then you can give phenytoin, and that's a good enough agent. Can you, and after you finish giving the phenytoin, and that, how do you give phenytoin? Somebody else has? How do you give it? You give phospheniton or phenytoin?
Sir, phenytoin, for
Phenytoin is
phenytoin,
a
we have
better
to
option over
calculate on
phenytoin.
like phenytoin equivalent.
Yeah. So how much do you give it, and how fast do you give it, and what do you dilute it with? Anybody else can answer? How do you dilute it?
In NS, not in dextrose, that will, as it
Correct.
will be.
Correct. So you give it, and what are the important things? Phosphainton. If you're giving it, how fast can you give?
It should be given over 20 minutes under cardiac monitoring.
Correct. But the thing is 3 milligram per kilo actually. Phosphainton, you can give it 3 milligram per kilo, and phenytoin is 1 milligram per kilo per minute. So if you're giving it, say, at a 3 kilo baby, and you're giving 60 milligrams, then a phenytoin, suppose, because a phenytoin equivalence is about 1.5 times, right? So say you're giving 20 a phenytoin equivalence means you're giving 60 phenytoin equivalents, then you can give that much faster. So 3 into 3 would be 10 milligrams almost per minute, and you can give them about 6 to 7 minutes rather than in 20 minutes. But obviously cardiac monitoring and all that kind of thing, because some of these patients may have decompensated cardiac because of HIE and all these kind of things. So you have to be a little careful. Okay. And then later on, if it continues seizures, what do you do?
Medas, so generally we give for Medas drip, Medas coma.
No, Minascoma.
No, sorry, Medas drip we give. We put on a
Yeah.
Medas drip. 33 microgram.
Fine. I think that's about the drugs. Anything else? I mean, typically, if you are in a good ICU and all that, how would you manage this besides drugs, and then just leave the baby, or what do you do?
We'll put an
What
Sir,
should
early
you do?
continuous.
Let's assume you have all the facilities. You
We'll
have all
start
the
a con-
facilities. Huh?
We'll start a continuous EEG for the patient to see the
Yeah.
localization or the
No,
discharges.
not localized. No,
Discharges.
you're not looking for. What are you looking for in EEG?
Sir,
Continuous EEG?
sir, we are looking for a estimation of seizure load, that is, and therapeutic target monitoring, that is 70 to 80% of the burst suppression should happen.
No. That is if a patient is in status epilepticus.
Okay.
Status epilepticus means ongoing seizures. The only time the EEG monitoring is done primarily because when you give anticonvulsants, you do what is called dissociation, electroclinical dissociation. And that's why what happens is many of these patients, in fact, there are two types of seizures in neonates. One is electroclinical seizures, where you have electrical activity coinciding with clinical seizures, and then you have electrographic only seizures. So very many patients, usually HIE and is badly insulted, they have only electrographic seizures. And you may have no other clinical seizures at all. Or you may have a few and then they go away and you think everything is kosher, but it's not, because it's still going on inside. That's why you do EEG monitoring for at least 24 hours. And to confirm that, in fact, seizures have not continuing inside the brain. Because then you may have to, of course, this is enough situation where you have all these facilities available, but in a theory question, there's nothing wrong in answering all this. Because they are not telling you that your patient is in the village. A patient may be in a high-class hospital where everything is available. So those kind of things you can do, you must do. And if you do not have a continuous EEG, what can you use? AEG, na?
AEG, amplitude EEG.
Amplitude integrated EEG. So that is something which is there in many hospitals in Bombay, where you have a couple of channels running and you can actually see for that. And that's something which you can train. People are neonatologists, people, pediatricians are trained in reading that. You don't require an expert to read these kind of. So I'm not saying that this is something. I'm just saying when you're writing about something, you can just mention all this. Immediately you'll tell the examiner you know a lot about this particular problem. I think anything else I've forgotten to mention? We've gone through everything. The workup, of course. What is the workup besides your sepsis workup and CSF and metabolic and all you've done. What else do you want to do in a place which is everything is available?
So if we have not found a cause yet, we'll go for
One
imaging.
minute. When somebody else wants to answer this, say Sonali, you haven't answered for a while. Somebody said MRI. Why MRI? You
We
can
go for
answer. Put on your 1 minute. I'll
ultrasound.
let. Okay. So it depends on what
Pathology,
many
yes,
things.
yes.
Yeah. So what? Yeah, exactly. So if you're suspecting a preterm baby, you want to know whether there's hemorrhage. Ultrasound should be more than enough because usually babies can't be transported easily. Even if you have an inpatient MRI, in-house MRI, the problem is preterm babies, have because of high problems with keeping the temperature okay and all that stuff. It's a little difficult to do all this. So obviously ultrasound with the. But if you want to say, for example, you already have a story of HIE, which is quite definite. When would you do MRI? Why would you do an MRI?
So to know what area is affected in the brain.
And do after that, what will help? How will that help you? Yeah, somebody said prognostication. So when is prognostication important in this age, in this first few days of life?
Because it can help us planning the early intervention therapy.
Arey Baba, early intervention therapy will be done anyway, na, even without MRI. You are doing it only if you are going to think about termination of care. So if that situation comes up, you have a baby who is severely asphyxiated, and then you're thinking about not improving, not coming off the ventilator. So you have a chance at that time to tell the parents that, listen, if you do an MRI and we find extensive injury, maybe we can think of, you can think about, you can think about discontinuing care and let nature take its course, because this baby will be severely affected. So you require an MRI at that situation. You understand? You obviously require an MRI whenever you don't know the etiology of the seizures. For example, if you don't know somebody who did not have HIE, there's no hypoglycemia, there's nothing, you want to know that. Then, of course, you may be missing some metabolic condition which might help you. The MRI might help you. Otherwise, just to do an MRI in the acute stage doesn't sound really necessary in most cases, especially if you have already a diagnosis. So neuroimaging should be reserved, especially MRI. And which particular, if you want to do an MRI, what are the sequences? This might be a bit too much, but which sequence must be used?
T2, because they were not myelinated, so we cannot.
No, not T2. Anything else? Anybody knows?
DWMRI.
Yes, DW, diffusion weighted MRI. So that is the one thing which must be done. So if you can't get it done in your hospital, and don't ever send the patient out for an MRI. You can't send a very sick baby out, say, go to this center and get it done. Aisa mat karo. If you have an inpatient MRI, easily available, your people are very, used to transporting young kids downstairs to the MRI or wherever it is, go ahead. But otherwise, don't do it because you might make the whole thing worse. Okay. What else? What other important things besides correcting metabolic? Anything important in the management of, for example, somebody can tell me about HIE?
Therapeutic hypothermia, we cannot have that.
Yeah, how many people do it from you people? How many of you must be working in different countries, different hospitals? How many of you do it? Because it's almost,
Sir,
it's not
we
commonly
are
done.
doing.
That's good. So whoever is doing is great, but unfortunately it's not being widely done. So tell us about how do you do it? Which patients do you choose for this? How do you do it? Just tell us.
Sir, the baby should be full term and the weight should be more than 2 kg. 2 kg, birth weight should be more than 2 kg. And there is history of birth asphyxia. Within 6 hours, we will start therapeutic hypothermia. The temperature we keep at around 34. 34.
Does the stage of HIE matter?
Yes, sir. It matters.
So,
Uh,
so which is the
So-
stage is it definitely helped by hypothermia, and which is the stage where you definitely won't do a
First and
hypothermia?
second.
first and second
First and
stage,
second.
it helps.
Actually, you don't require to put a more. If I am not wrong about this, stage 1 you don't use hypothermia. So if the baby is just irritable and there's not significant acidosis and all that kind of thing, you don't necessarily have to, because it helps basically stage 2. But I might be wrong, you better check that. But stage 2 definitely helps. Stage 3 also you do it, but stage 3 it might not help. And you give them the benefit of doubt and do it, because it's very early to do staging. In the first few hours, it's very difficult to stage also. Baby is sick, you're trying to arrange everything, so you don't have time to decide that. But the baby is conscious and crying and this and that and everything is fine, the only thing is a little jittery and all that, I won't push him into hypothermia. But definitely somebody who's having seizures, who's lethargic, hypotonic, this, that, now you don't know whether it's stage 2 or stage 3. Stage 3 usually doesn't have many seizures, but that's all, theory. So it's very difficult. In those situations, definitely within 6 hours, you have to do hypothermia, and you keep them in mild hypothermia with 33, 34 degrees, if I remember right. And, people in India have done, even without the hypothermia blanket, people have used ice packs on the head and all sorts of things, and quite ingenious methods, and they found that it works as well. So really you don't require expensive equipment, but if you don't do it, send the baby out to get it done somewhere where it can be done. So this is the one thing which is just missing in all many neonatal units, especially in the private sector. Okay, shall we go on to the case, Rajesh, or you want to ask any more questions?
Can I ask one question? Sir,
Please go ahead.
Storadip said that if we advise MRI, then it's better to do DW MRI, sir. What is the reason behind it?
Yeah, so diffusion weighted MRI is basically it is a method of diagnosing cytotoxic or cellular edema. So it shows up as positive very early in the course, especially in conditions like hypoxic ischemic encephalopathy, hypoglycemia, and those kind of situations. So you get very early. So if you do a T2 weighted MRI as a normal MRI in the first few hours of life, if you have to do it, for example, hypothermia, you want to know whether there's whatever it is, whatever reason you're doing it, you might not pick up anything on the T2. T2 is very difficult to even normally is difficult to see after a few days. Then somebody's talking in the middle. Can the host? Hello, Rajesh. Can something be done?
Yeah, carry on. I think carry on now.
No. So basically, I think there was we were talking about TWI. So DWI is important in these situations, and it usually comes up within the first few hours, but up to a day or two, and then is positive much before the T2 becomes abnormal. So you want to know the changes, when even if T2 looks normal, the DWI will not be normal. That's important. If you don't have DWI, you might be mistaken in thinking everything is normal when it's not.
Yes,
You got it? Did I answer that question, or you want me to repeat it?
yes, sir. Yes, sir. Yes, sir. Thank you. Thank you, sir.
Yeah. Yeah.
So
What do you want to do now,
I
Rajesh?
think just to summarize, as Udani sir said, when you are writing an answer to approach to seizure day 2 of life, you must get your headings correct. So your first heading would be confirm that it's a seizure. So you will write that as a heading. Then you will ask about history, also all those antenatal, intranatal, perinatal, whatever history you want to ask. So you have to write a heading that I'm going to ask history of all these things. That will tell you a possibility of what the cause could be. And then, as he said, you list the commoner causes first. That is what is going to get you the marks, because when they say day 2, they want you to talk about what is possible on day 2 of life, and then you talk about investigations and management. If you want, you can, as someone said, you can put it into 2 parts, that if I see the baby seizing, then I'll first look at ABC, manage, and then get into all this. And if the baby is not seizing just now, then I'll get into all this. So this is the way you have to structure your answer. That's the point of this session. I think now we can, and since it is approach, the first part is more important. Detailed management is not important because it's the approach. So you can just write your headings. Management means specific treatment will be according to the cause identified, and just list that. We can now go on to the case.
I cannot share the PPT. If you can ask the host to disable.
Nilesh, Vinod, allow Ayushi to share screen. Nilesh or Vinod, who's there? I am calling him up, Ayushi. Meanwhile, maybe you can just start orally presenting, but I'm calling him up.
Yes, okay. So I'll start orally. Meanwhile.
Hello.
Who's going to be discussing this case? The same people or some different people? Or because I think the way we go
Nilesh,
about it.
आयुषीला स्क्रीन शेअर करायचं आहे, तर तिला परमिशन दे किंवा होस्ट बनव.
तर पोस्ट केलंय त्यांना.
Okay, I sir, now he has done a lot. I'll share. Can you see the screen, sir? Sir, is it visible?
Yes, Ayushi. Go ahead.
So my patient is Kavya. She's a 4.5-year-old girl. Only child born of non-consanguineous union, resident of Malad East, Hindu by religion, informant being mother, and she was brought by parents with complaint of delayed attainment.
Full screen.
Yeah, yes. I'm doing it. One.
It's not happening. I don't know.
Yeah, so is it okay now?
Yeah.
So with complaint of delayed attainment of milestone, noticed by parents since 1 year of age, sleepiness since 1 day, and complaint of vomiting since 1 day. History of presenting illness, parents noticed that the child had delayed attainment of milestones since 1 year of age as compared to peers. She attained neck holding at the age of 1 year, and she has not attained sitting without support yet. She is still at sitting with support for some 2 to 3 minutes, and then she fell down. Parents also noticed some trembling of upper limb when made to sit and lower limb when made to stand. And they also noticed some continuous abnormal movements of hands since 3 years of age. Child initially had some stiffening of limbs and difficulty while making her wear diapers. So,
sorry, what is the age of the child?
Currently, she is 4.5-year-old.
4.5, okay.
So development history wise, child gross motor wise, child started holding neck at the age of 1 year. Sitting with support was 1.5 years. Without support for 1 to 2 minutes, 2 years. But if she's made to sit, she cannot sit by herself. So she has not attained that milestone yet. And there is no rollover achieved anytime. In fine motor, there is no hand regard. There is no bidextrous support. She does not reach to any objects. And she keeps her hands open. Speech wise, she started speaking some monosyllables since 6 months of age, and there were no bisyllables actually.
What is your, first of all, you should never say speech. You should always say language.
Languages.
Okay.
Yes.
So what are the language milestones you asked for?
So I've asked for receptive if she's responding well to there are
what?
two languages. Recept towards the name, or if called by. They said that she's responding towards that, but in expressive language there was only my monosyllables.
No, you only one thing you asked about receptive language at 4.5 years.
So she has. I should have asked about other things.
Anybody else tell me what else they want her to ask? What about Dr. Aditi Shah? Do you want to?
Sir, she's our organizer. She's not
Sorry,
the student.
I just saw the name. Yeah, sorry. Somebody else can answer because she is only asked about the name. So anybody wants to answer what else they want to know?
Yes,
We want to ask if the child has understanding of verbs and nouns. Like first nouns like where is mother or where is father and where is
How can
your
you ask all? How can you have a you want to know when does it? I mean, nouns and verbs is not, that's a really theory here. What should you ask for when you want to know whether the person understands or not? You want to know whether he understands his name?
Gender, if he's a boy.
No. Whether he understands his name, whether he obeys commands, whether he knows common objects, whether he knows body parts, whether he knows pictures, all this comes in sequence. Initially at 5-6 months, how does this milestone start? At 5-6 months, you know your name. At 9-10 months, you start obeying. 9-10, maybe even 12 months, you obey commands. You basically start knowing objects by that same time, maybe body parts by 15-18 months. By 1.5 quarter to 2 or 2 years, you know some pictures. So this is the kind of receptive understanding of language which you should talk about. And nouns and verbs, please don't say that in your practicals, because that means you have never done it. You're just reading from the book and saying it. Please. So receptive language, you should ask these few things. You don't have to ask everything, but at least obeying commands, knowing some of common objects, knowing people in the house, mama, papa, uncle, dada, etc., etc. All these people. And when you say expressive language, what should you emphasize on?
She's vocalizing well if right talk.
Vocalizing is not important. You should know what exactly, is it a meaningful vocalization or not a meaningful?
Meaningful vocalization.
So meaningful means, are you calling mama, mama? Are you calling somebody, you're using a word to express a give me, so you're saying they, nai, no. So all those things you should ask. Expressive language is important in that. Babbling and making just doesn't mean anything. Okay. Go on.
Socially, she started, she was always delayed. She never had any stranger anxiety. Social fights, she started having like at 6 months of age. She has started responding to name and fixing and following since 4 years, since 6 months back only, after the treatment was started. Development quotient now is 33% in all the domains, including in all the domains. Now the child has...
Anybody want to ask her a question? What is the first? Okay, shall we do one thing? You finish. I want to finish the developmental thing now because she's coming to something else, now vomiting and all this. But anybody want to tell us what kind of delay this is? Go back 1 slide, 2 slides.
Global developmental delay in all the domains.
No, global developmental delay, yes.
Yeah.
But is it more in one sphere or less in one sphere, or is it a global? Yes, it's not absolutely specific, but there is something which is a little odd in this.
Motor more than language and social.
Anybody else can answer, please? Is developmental delay in the gross motor and the fine motor the same?
No, fine motor is more than gross motor, and it is more than language as well.
So what is it? So why do you say that? That fine motor is preferentially is worse. So what is the fine motor age for this child?
0. Matlab has not achieved anything. 3 months.
Zero, no. Keeping your hands open, you only said that would happen between 2 to 3 months. So first, how do your fine motor develop? First you have your fisted, then it opens up, then you start, you hold things given in your hand, then you reach out bidextrous, then you go unidextrous. All those things. In the middle, before that, you also put things in your mouth. So all these things are basically fine motor. And what you're saying is she's less than 3 months. I mean, she's about 3 months or maximum 3 months in fine motor. And what is the gross motor?
Gross motor, she has reached up to sitting with support to some 9 to 10 months.
Correct. So there's a big gap in that. No?
Yeah.
The other thing which is odd is there's no rollover at all. Why do you think there's no rollover?
Because of the tone, maybe.
Anybody can answer? What do you need to
truncal
roll
weakness. It's a truncal weakness.
over? How has she's got truncal weakness, but she's sitting without support, no?
She's sitting with support.
Sitting with support. So the problem is rollover, you need your hands to roll over, no?
Okay.
So maybe she's not using her hands and that's why she is not being able. It's very odd to have no rollover and have sitting with support. It's a little odd. You better check that thing. Okay. So what are the social milestones you asked? You said fixing and following. Fixing and following is, you're saying this, fixing, following what?
So if then an object is shown, she's trying to fix the object.
That's vision, right? So social milestone is interaction. Huh? So eye contact would be important to humans. Following the face would be important. Social smile would be important. Imitation would be important. Bye-bye, tata, interaction. All these things are important. Then you come to the social milestone later about, but all these things are, I'm not sure, in response to name, like I said, is receptive language really, but not so much to, okay. So I think there is a global delay, but there's more in certain areas. I think that's important to get in this case. Okay, go on.
So now when the child was brought to the hospital, she had come with complaint of lethargy and decreased oral intake since one day and vomiting 2 episodes since one day. So in negative history, when asked, the child had no fever, cough, cold, or decreased urine output, just to rule out any current infectious episode or any. There is no history of seizures or persistent fisting of hands. There is
What
no
is
history.
what is the missed day dosage?
The child, I'll come in the treatment history. They said that the child is on some medication. So just to rule out that she has not missed on any medications as she's lethargic or taken any extra dosage that made her lethargic.
Okay, go on.
So no history of difficulty in feeding or nasal regurgitation or repeated LRTI, just to rule out that she has no difficulty in swallowing, ruling out suitable for bulbar palsy, and no history of bed sores or arcing of bed sores, to just rule out any complication history as the child is developmentally delayed. So just to rule out if she has developed any complications related to that.
See, on direct questioning, first of all, you should, in my opinion, I don't know what the DNB expects, but you don't try and find out signs. So bed sores and arching and no history of, if there's arching and she tells you, fine. But if there's no history of arching, means what? So suppose there's no history, but when you see the patient, there is arching. What is more important? What do you see? No? So, fisting of hands. I mean, who will tell you about fisting of hands? The parents are going to start looking at the hands and saying the hands are fisted. I forgot to tell you. So these things are examination points. What is important? Okay, history of seizures, history of feeding. Yes, so you want to know if there's an associated problems in hearing. So I don't see anything about asked about hearing, because kids who are delayed may have hearing issues. So they, does he respond to name? Does he respond to music? You say it doesn't respond to name. Does he respond to music? Those kind of things. Does it startle?
Sir, I said she
All those
responds
things.
to names. So do I need to say it again in the next?
Okay, fine. You said that it had happened at 4 years, but that comes
Yeah,
in the course. I mean, it's a bit confusing. You give your developmental history, and then at 4 years this happened. Okay, so maybe not that, but vision you mentioned about. Also, things like feeding is important because you want to know whether there's any problem. Weight gain is important. All these are important histories to know associated problems. But then second important thing about direct questioning is what is the anything else in the direct questioning? Or this is over. Maybe I'm go to the next page.
So treatment history I've come to.
I don't see treatment of what.
Because she has the developmental delay since 1 year of age. So they have been visiting to multiple doctors for the same.
Anyway, your most important thing is your developmental delay, correct? Or your main focus is on the developmental delay, or the main focus is on the vomiting and lethargy for 1 day?
Developmental delay. Developmental delay.
So if you have a specific, so what I would do, frankly, if I were you, is because you brought this acute history in the middle, so you can say for acute history you give a little different questions. So this patient having vomiting, and does the patient have this before also? Was it a regular feature, or once she just became a little drowsy and vomited 1 day and that was it? This is the first time that's happened. So that may be some intercurrent illness or something of that sort. So you can give a little bit on that, but then you focus on the developmental delay. And if you're going to focus on the developmental delay, you need to have direct questions for two things. What are the other associated problems the baby has? Like you mentioned, hearing, vision, feeding, weight gain, all that things. Second important thing is etiology. So you've got to give your etiology. So what kind of questions you want to know? What are the etiologies of this?
So ENC history, I've asked that consanguinity, if there is a syndromic child with consanguinity.
So then those are questions that but you must mention what, for example, what are the common causes of developmental delay?
So and any birth history significant CP.
So prenatal, perinatal, and postnatal.
I mentioned it.
So you got to mention it. You got to examine. Your examiner should know you ask these questions to find out these three things.
Okay. So I have a doubt.
So you should know.
So I have mentioned that it after in birth history and antenatal history. Should I mention it in negative history in exam, practical exam?
I mean, I personally, I think it should come here, because otherwise you can, what is the general format of Rajesh in your DNB? How do they expect it? Because what's the point of asking, all these, in the sense you're looking for etiologies. If you want to mention it now, you can mention it now. They're looking at the...
No, so see, you can probably say that on direct questioning, you are trying to rule out some etiologies. So you say on direct questioning, and then you ask some relevant questions related to ruling out etiologies. But it should be restricted to those possible for this child in this scenario. You don't just tick your 20 causes which are given in the textbook.
Correct. So I think that's the way I would approach it. So first would be the developmental, because over here the patient has come from primary developmental problems. So you want to know about delay. Why you say it's delay? Where it's a specific motor delay, a specific delay. It's the global delay. If it is a global delay, some areas are more affected. For example, let me ask somebody, this is an open question. Which patients have more of social and language delay and not so much of motor? Everybody knows this, right?
Autism patient.
Which patients may have a global delay, which patients have more motor delay and less of language delay or less of social delay?
Peripheral, SMA and peripheral.
Yeah, they have purely specific delay. They don't have global delay at all. So neuromuscular conditions, usually, I'm not talking of all neuromuscular, but SMA, for example, the social and all is perfectly normal. And if the baby is old enough to live, the language is also normal. So those are specific delays. But for example, a global delay with more affectation of the motor and less affectation of the social and even maybe at least some language. Anybody can tell me?
Cerebral palsy. And
Cerebral palsy, correct. Cerebral palsy. So all these things should come out in your history. It helps us to understand one, what is your syndrome? Syndrome of, is it from the history? Is it an autistic syndrome? Is it a global delay syndrome? Is it a, cerebral palsy? I mean, that kind of thoughts which should come in your head. And the story about the etiology should also be there. So I say that this patient was born of a non-consanguineous union, which you did mention, right? Non-consanguineous union. You said, huh?
I have mentioned it in the starting. It's a non-contact.
Yeah. So all those things which make you, for example, so okay, go on. Let's not belabor this point. Let's go to the next thing. Okay, go on.
So ANC and birth history was normal for the child. He was a germ gestational vaginal delivery. Immediately, baby cried immediately after birth, and birth weight was 2.5 kg, discharged. There was no history of NICU stay or no history of NNH or convulsions. There was a history of caput succedum, which was maximum at birth and decreased over 2 weeks of age. He passed during meconium within 24 hours of life. So basically, in a conclusion, ANC and the birth history were not contributory to the cause.
When you say ANC normal, I mean, you just say normal or do you give some specific things?
So, specific things like here.
Like in the sense that the patient had a normal antenatal follow-up, there was no diabetes, there was no infections, all those things should be mentioned. I think to explain to the examiner that you know all these things. When you say ANC is normal, I think those important things. Was she followed was a regular follow-ups, all these things you can mention in brief.
I mentioned earlier, I thought
otherwise, if you don't have time, you can say ANC and birth history normal. Move on. You understand? Because you've given a lot of details for the birth history, but not much for the ANC.
So ANC history, my mother was 23 years old and married life was 2 years. Post-pregnancy, there was a weight gain of 8 kgs. She was T1, registered pregnancy, diagnosed up to at 2 months of pregnancy. First scan was at 3 months, which was normal. She received iron and folic acid post-conceptually, not preconceptually. And she took 2 doses of TT. There was no history of drug or with rashes, fever with rashes, any drug intake or any radiation or hyperemesis. Knuckle scan was normal. In T2, second trimester also, there was no history. There were she started feeling Kyuknik at around 6 months of pregnant gestation. And anomaly scan was normal. She was taking iron, folic acid, and calcium then. And in third trimester,
summarize all this. Yeah, okay. You don't have to go into many details. Just summarize it. Fine. So she was followed up with ultrasound and regular follow-ups with the gynecologist, obstetrician, and there was no apparent complication at all with any diabetes, infections, or anything, or any drug intake or whatever. Fine. Now go to your.
So summarize the Kavya, 4.5-year-old girl, born of non-consanguineous with no significant family, antenatal or birth history, with complaints with global developmental delay, more in the fine motor.
You didn't tell us anything about involuntary movements. What are those involuntary? Can you describe them? What were they kind of? Because you just mentioned it and then never mentioned any details about that.
Yeah. So as per the parents, there were continuous involuntary movements in the hand. So I thought I will explain in the examination what I saw in the patient.
No, but are they present in sleep? Are they not present in sleep? Are they I mean, what is the?
They are present. They are not present in the sleep. They are continuously present over the daytime. As per the parents, no precipitating or precipitating or relieving factors associated. Yeah, and they started around 3 years of age.
Achha. Okay. They were not there before.
not noticed before. So Kavya, my patient, is a 4.5-year-old girl, born of non-consanguineous union with no significant family history of antenatal or birth history, with global developmental delay, more in the motor domain compared to language and social, and maximum in the fine motor domain comparatively to other domains, and involuntary movements of hands with no seizure disorder, most likely involving gray matter. With the since it's an involuntary movement, I'll consider it can involve upper motor with basal ganglia, and probably a syndromic association.
I think you're biting more than you can chew. I would just use the word that I have a girl child who's having developmental delay, which is global, and which seems to be involving the fine motor, and maybe there are some movements affecting the hands. I don't know whether it's hands or leg, but you haven't mentioned that. Some movements, and this seems to be a involvement of the nothing, not necessarily gray matter and all that, because you don't have any seizures, and how do you, and you haven't even seen the movements and you're diagnosing. I mean, basically this should be coming afterwards when you examine the baby and all this. Before you're not confirmed what these movements are from the history. You already come to the localization. That's a bit stretching it a bit far. Okay, we all, if somebody else can answer what this, who has not seen the baby, what this baby might have, because
Rett syndrome.
Why do you say that?
So developmental delay and involving the hands. Usually,
so what happens in Rett syndrome?
Usually there is regression of the milestones.
No, there's arrest of the milestones. So in her situation, if she was suspecting this, I would have been very careful about saying what happened in the first 6 months. So the Rett syndrome comes up between 6 to 18 months. I'm just saying that is one of your diagnostic possibilities, because everybody seems to be, you need to therefore confirm that the early development was normal. So was there having eye contact? Was the baby having eye contact before? Was there smiling at the mother before? All these things are early milestones. Maybe she noticed the problem at 1 year because the first 6 months she was okay. You understand? And then afterwards, what happens is there seems to be an arrest of the milestones. And did she ever use a hand? No. So there is purposeful hand use is not there. That's why it's important. So whenever you say Rett syndrome, these are questions you should ask in the history. You won't get it from the examination. You don't know whether the first 6 months was normal or not by looking at the examination.
I wanted to ask, if the mother noticed head holding by 1 year of age, obviously she did not achieve the first milestone of head holding by.
No, but it could be social milestone may have been normal. No?
Either of the milestone should be normal, and then there should be a rest.
Yeah, I mean, in the sense, you have to go into details about the first few months of life, because when a patient comes to you at 1 year, when the patient has been noticed as abnormal, the first 6 months are not generally inquired into. So if you want to, I'm not saying it is, I don't know whether it's Rett syndrome or not, but if it is, then this is the things will help me confirm it from the history. You understand? Okay. And please don't mention, on the history, I gray matter, upper basal ganglia. What is upper motor basal nuclei? I don't know what that means also.
No, sir. Actually, since there were no seizure involved, I was considering it gray matter, and there was no during.
No, you're saying gray matter with no seizures. That's exactly the opposite.
No, sir. Involuntary movements were there. So, involuntary movement can be seizures. So, involuntary movement will come under white matter or gray matter.
I understand that, but you're confusing everybody. You're saying involuntary movement with no seizure disorder. And then you're saying involving gray matter. And you go on all the way to upper motor. What is upper motor basal ganglia? There's no lower motor basal ganglia. So upper motor is, yes, upper motor neurons is basically of the corticospinal tract. Now, when you talk about that, all those things you should not mention in your historical thing. You just say, this is a girl child. If you are trying to put forward this thing that this is Rett syndrome, then this is a girl child who has come with a global delay and maybe their arrest. Maybe I don't know if you got the history of arrest, if not, fine. And then there is some significant deficiency of fine motor use. That's important to mention. The purposeful hand use has not been developed at all. Okay, go on.
So on examination, child was conscious, alert, comfortably lying on the bed with upper limb flexed and lower limb extended in that time. Fixes eyes when called by name, and occasionally child was smiling. So vitally, child was stable. Heart rate was 96, respiratory was 22. Peripheral pulses were well felt. CRT was less than 3. BP was 92/60, that is 60. And SpO2 is 99% on room air. And then on head to toe examination, the child had a small head.
1 minute. Go back to the, when you say mental examination, conscious and alert. I think it will be better if you give how the child is interacting. So you mentioned there was on examination, there was eye contact was there. You said eye contact was there. You think there was social smile or not really social smile, was smiling by herself?
Occasionally smiling by itself, but not like if I am calling then.
Spontaneous smile could be nothing to do with social milestones. So social smile was there or not there?
No, he was not. When called by, then if I'm looking at the.
No, not call. When you go social smile, when you look at your face.
Yeah, he was not smiling.
They don't have to hear their name. They can go there and you play with them and they have that smile. Was that there or not?
No, it was not there when I was looking at the.
Correct. So there was no obvious social smile. Was there any stranger anxiety?
No, the child was not crying with all the children around.
Correct. So all that is important in the mental status.
Okay.
Okay. Go on.
I'll start with the anthro. So he had a weight of 15 kg. He had the weight of 15 kg, height of 96 centimeter, and height circumference of 45.5 centimeters, which was below third standard deviation for her age. So she had a small head, most likely small head pointing towards a microcephaly. Her AF was closed. There was no corneal clouding or in eyes. There was no signs of vitamin A deficiency. There was no low set ears or no nasal. There was no syndromic facies on examination. She had kept her hands open with no cortical thumb. She had stereotypies. Continuous breathing movements were there on the hands. No vitamin deficiency signs were there. No cutaneous marker signs were there. No contracture on bilateral ankle was present.
Why do you want to ask about vitamin A deficiency? So, because you read xerosis.
So,
any particular reason or?
So generally global developmental children are associated, but they can have malnutrition or they can have low diet.
Okay. Well, go on. Okay, maybe.
So on supine position, child had extended lower limb and flexed upper limb. When pulled to sit, there was head lag present. And when sitting, the child was partially curved. On vertical suspension, there was extended legs noticed. And on ventral suspension, head and legs were hanging down. I tried proning, but I could not.
What does all this mean? You said extended lower limb with flexed upper limbs. What does that mean?
So child was having hypotonia.
Hypotonia?
Hypertonia. He was scissoring.
Okay.
Then
I'm just a little confused when you talk about examination. Yes, you go on to school to sit and all those things. Yes, just mention that. Okay, and then you in your tone you think the baby is hypotonic or hypertonic, correct?
Right.
You haven't mentioned scissoring. That's what I'm saying. Yeah. Have you mentioned scissoring?
No, I have not mentioned scissoring.
Yeah. Okay. I did not now
understand.
she's responding to verbal stimuli following light.
Right-handed, the child was when offered something.
You said there was no hand used. No? How did he have right hand?
And so given a pen, was trying to hold.
So she's using the hands.
No, I got it by mistake.
Okay, go on.
Cranial nerves, olfactory, I did not assess. Third, fourth, and sixth, there was no sign of toxic or nystagmus. Seventh, there was no, there was no nasolabial fold absence, or there was no startle response present. And there were no cranial nerves disorder noticed in this time.
What is the startle response positively?
Sir, what happened when initially we tried doing startles, the child was showing some response, and later on the child stopped showing that response.
You're looking for something specifically?
No, not really.
So is startle abnormal or normal?
So at this stage, 4.5-year age is abnormal.
Startle, suppose I come behind you and say boo, you also might have a response. Would that be called abnormal? No, no. So any sudden sound or sudden whatever it is, you can get a startle response. No? If it doesn't habituate, then it's abnormal. And you don't look for it in a patient unless you're suspecting something like Tay-Sachs disease or something.
Okay.
You see, so basically, I think this doesn't make sense. Why you are asking for startle response? So you were thinking of, I think 8th you were looking for hearing, is it?
Yeah.
So instead of startle response, it may be better to use, if he's not responding to any human voice, use music.
Yes.
If at all you want to examine the 8th. But frankly, it's very difficult in young children to be sure about whether they hear or not by calling out or doing startle response. I mean, startle may be, if you do it in front of her, you might even she may even feel the vibration and have a startle. So I'm not very sure that means. Okay.
So cranial nerves are normal. Posture wise, child was an adducted internally rotated, as shoulder and elbow was flexed. Lower limb, extended hip and knee and bilateral plantar was flexed. There was no wasting in the muscles. Then the power was 3/5 in all the limbs. The best visible power I saw in that child.
Just her anti-gravity movements were present. Okay.
Anti-gravity movements were present. Reflexes wise, there was no Moros or ATNA, no primitive reflexes. Neonatal reflexes were not there. Grasp was present.
Grasp reflex is a primitive reflex or not?
Yeah, it's a primitive.
So is it present or not present?
No, sir, it's absent.
So what are the primitive reflexes which, if they persist, so what are the ones you consider abnormal at this age?
ATNR, if it's present, it's an abnormal reflex. Moros is an.
In fact, all primitive reflexes would be abnormal at this age, no?
Yeah.
So if the grasp reflex is present, that is abnormal. So was it a voluntary grasp? You're saying it's a voluntary grasp or an involuntary grasp? And how do you tell the difference? Anybody can answer that. You can answer in the chat also. I'm looking at it.
Sir, voluntary grasp is when you give something, baby starts, baby grasps, and involuntary is without will not give her anything if there is something nearby area, and he starts grasping. Then we'll say involuntary. And no, in this age, grasp reflex, if it is present, then it is abnormal.
Correct. But grasp reflex, if you want to examine, you're not sure whether it's normal or abnormal, you stroke the back part of the hand. If it opens, then it's probably an involuntary grasp. And, voluntary grasp, basically, involuntary grasp is very strong. Basically, if you stroke the backside of the hand, it should open. But it's sometimes difficult to tell, of course. over here, I'm a little confused. There was no hand use at all. There's hand stereotypies, yet there is a grasp reflex present. So I'm not
So,
sure.
so when we involuntary, I do not understand the voluntary one. If we give a pen or something, if the child is holding as a thoda bhi, so will it come in positive grasp or it will not come in the positive grasp?
No. In the sense, there has to be intent. Na? When you're using, when you're trying to have a grasp reflex, the patient will show a voluntary means he'll reach out for it and hold it. There'll be intent. So when you have a grasp reflex, it's not intent. You have a baby who's just born. There's no intent. You just put your hand in the palm, you close the palm. And as soon as you rub the outside palm, outside of the palm on the dorsum of the hand will open. So I mean that those reflexes are usually primitive reflexes are always abnormal at this age. When do they usually go away? The grasp. Anybody can answer. Anyway, go on. You don't think we have much time? Go on. Okay.
So there were involuntary movements in the hand, repetitive hand wringing movements are present.
What are those called?
Stereotypies.
Okay, stereotypies, fine.
Sensory wise, matlab, as far as I could examine, I did not find anything abnormal in sensory examination. I did not find any meningeal irritation in the child, and the spine was normal. There was no nystagmus noticed in the eye, so I'll say there was no cerebellar sign. That was the only sign I saw. And
all these things are more, cerebellar signs and all that. Unless it's obviously, it's very difficult to test for cerebellar signs in such a delayed child. She's not holding on to anything, so it's very difficult to, or she's not reaching out for anything, so it's very difficult to get. And she's not yet sitting without support, without support, so it becomes very difficult to check balance. So when you say cerebellar signs, what do you mean? You really can't. Sensation, don't even mention it, because unless you're pinching her or something of that sort, how do you tell sensation? You understand? So I think those don't mention things which are not possible at this age. Unless it's obviously that she's having titubation or something, then you mention it. Otherwise, no cerebellar signs doesn't make any sense.
So what is titubation?
Titubation means the whole body shakes. No? Your head shakes, the body shakes in a patient who's ataxic. That can happen.
Other customary examination was child was normal. So at this stage, my child 4.5-year-old Kavya with complaint of global developmental, with no history of birth, no significant birth antenatal history, with complaint of global developmental delay, more in the fine domain compared to the gross motor and language domain, with involuntary with stereotypies present in the hand, and less purposeful use of the hands, was pointing towards upper motor neuron disease, most likely because of the stereotypies, most likely in the basal ganglia region.
My goodness, why are you coming again back to the basal ganglia?
Upper motor neuron disease. That's it.
So what are you calling it? You're calling it cerebral palsy.
No.
Why not? You're saying there's upper motor neuron signs, there's clonus, there's spasticity. It's a global delay. So what is the definition of cerebral palsy?
Cerebral palsy is a static insult on the brain which shows progressive symptoms.
Cerebral palsy is a disorder where you have non-progressive disturbances in tone, posture, reflexes, etc. So basically tone, posture, and other things. So basically motor system is involved. You may have other systems also involved, so you may be intellectually delayed as well and all that, but cerebral palsy is a condition which you're describing that. Now, your patient is having non-progressive and is having spasticity and all that.
So, but
I think whenever you come to a diagnosis, when you come to a diagnosis, Yeah, it's best to sort of don't just jump to the etiology as Rett syndrome because that doesn't give you any brownie points. What you need to do is say this is a girl who's come with no obvious reason for her global developmental delay, where child has significant fine motor delays as compared to other delays, and has uh, therefore we think it's Rett syndrome. But there are many problems with your Rett syndrome diagnosis. So what is the tone in Rett syndrome, for example?
Hypotonia.
Usually it's hypotonia.
Yeah.
Second thing is in Rett syndrome,
Arrest.
one of the features which should be there?
Regression or arrest of milestone.
Autistic symptoms. So child doesn't have social smiles. You should mention that. That he has, no? Doesn't have social smile, doesn't have visual contact except with, I don't know whether he's having human eye contact or just with, so I don't know that, but autistic features are there. Though I must admit that Rett syndrome, eye contact may be present. So generally, what are the criteria for Rett syndrome which you diagnosed over here?
MEC gene criteria. There are 3 criteria.
No, not gene, clinical criteria.
Neuroregression or arrest of the milestone.
No, developmental, first of all, normal early milestones. Number 2, female, obviously. So female, normal early milestones, developmental arrest, which occurs for a while, and there may be some regression, but not much. But the arrest is the most important. Lack or regression of purposeful hand use. Acquired microcephaly. That is important. So your head circumference goes down over time. So in the beginning it may be normal, but you may not have those circumferences. So you may have to say that this is microcephalic now. And finally, hand stereotypies. So these are some of the criteria, and they're usually hypotonic. They also usually have poor growth all over. Over here, your growth is very good, no? The height is 96 centimeters, which is very good height, no? So generally, they have growth failure also otherwise. It's not just the head size that doesn't grow. So I'm not saying it's not Rett syndrome, it may well be, but it's a very atypical thing, what you're saying. Okay, go on.
That's it. So in this case, differentials will be then CP, then Rett syndrome.
I think what you need to do is, unfortunately, we can't confirm your signs. But generally, I think important thing is that you try to, at the end of a developmental case, you try to find out which syndrome, clinical syndrome it is. Is it only global developmental delay? What is global developmental delay? Up to what age can you call it global developmental delay? Anybody can answer.
5 years.
Yeah. So why? So after 5 years, you don't call it global. And people are using global development at the age of 10 years also. So don't use that. After 5 years, if the delay becomes permanent, then you call it ID, intellectual disability. Second thing is cerebral palsy. Third is autism. So these are the 3 main things. And the fourth, of course, is older patients have learning disorders. So these are some of the clinical syndromes. Now, this particular patient, you can say one of those first three ones. In that situation, from your story, it looks like there's global delay, yes. Along with that, there is specifically also cerebral palsy symptoms, spastic cerebral palsy.
Yeah.
So I'm not saying, but so I'm not very sure you can come to a diagnosis of Rett syndrome with significant amount of spasticity and clonus and all that.
Sir, if CP, what kind of CP this will be?
You tell me what are the different types of CP.
One is central CP, which involves basal ganglia, putamen, and
central CP.
Central variety of HIE, which causes.
No. Cerebral palsy is nothing. One of the causes of cerebral palsy is HIE. Cerebral palsy is a clinical syndrome of non-progressive disorder from the central nervous system where tone, posture, balance, etc. is affected.
So
Correct?
spastic
And
diplegia.
this can change. It may not be progressive, but because of many reasons, you might get secondary changes in the bones, you get joints, you might get deformities. So you might have deterioration in function, and there may be changing signs, but the condition is non-progressive. That's important. But it has to be only of the motor system, tone, posture, balance, those kind of things. So maybe, and therefore, if it's mainly tone, then you talk about spasticity, dystonia, if it's about hypotonia, and ataxia. These are the four things. Usually the first three are fairly common. The last one is the least common, the ataxic type. First, spasticity is most common. Dystonic and spasticity are the most common. So this is what is CP. Now, the causes of CP may be perinatal, prenatal, etc., etc., etc. But the syndrome can be these particular things. So you don't just come to Rett syndrome straight away. That's what I'm saying. Your story has to be very consistent. I agree with you. One of the differential diagnoses over here with the hand stereotypies and the poor hand use and a girl child and all that can be Rett syndrome. But that's, I think, before Rett syndrome, you come to the clinical syndrome diagnosis. I'm not talking of clinical syndrome in the sense etiology. I'm talking about the clinical developmental syndrome. Understand? Okay. Anything else you want to discuss? How are you going to manage this child?
So, the supportive care will be offered. We can ask for, there will be two basic supportive care, and then we can ask for the genetic testing if the parent, if it's a first child of the parents are planning.
First thing you always talk about your management is how will you investigate this child? So how will you investigate this child?
So
you go straight for genetics, is it?
No, not straight away. We'll see for the vision and hearing also for this child. We'll see for any swallowing difficulty. In that case, we'll rule out any GR difficulty she's having.
The first thing should be diagnosis of the condition. So any particular tests you would like to do
EEG
in a patient where you do not have an obvious cause, correct?
Right.
You do not have any obvious cause. You don't have any perinatal changes. You have nothing. So first thing, what will you do?
We can do an EEG and an MRI.
EEG help you. How will the EEG help you with your? You have to basically first do imaging. You might want to do a metabolic screen because you don't know the cause of this. Unless you are very sure it's Rett syndrome, fine. Then you go ahead and you can do the MECP too. But that is not, I think, in a pediatrician level, you should do basically what you require: thyroid, you require B12 level, you require a metabolic screen. All these things should be done. Along with that, an MRI. If everything is normal, then you think of genetics. You understand? So this is the management. Second is you look at for the management, you investigate for the associated problems. So if he has seizures, you might want to do an EEG for sure. If the patient has a possible hearing deficit, you want to do a hearing evaluation with the BERA or something. If there's a problem, you think there's no eye contact, you want to get an ophthalmic examination. So all these things have to be done. If your problem is poor weight gain, but over here the weight gain is very good, 15 kilos, so it's unlikely to be a feeding problem. And you haven't mentioned any feeding problem. So there's no point in doing testing for feeding problem. There's no obvious problem. But if there is, then you might want to do, all those swallow study and this and that. And then you investigate for, then the next thing is, after that, what are you going to tell the mother and father? If you reach a diagnosis, very good. Otherwise, how will you counsel them?
I'll explain the mother that this is a
before that, what is the treatment for this case? If you don't find a specific cause which is treatable, how will you treat them?
Symptomatic treatment will offer them. So
what is symptomatic treatment?
So we'll make sure that the child has no respiratory difficulty or any swallowing difficulty.
Therapy. First talk about
occupational therapy.
Multidisciplinary approach will do.
Exactly. So you have to do that. Because after you finish your diagnostic workup, you finish the diagnostic workup of the associated problems, then you have to basically talk about therapy. You give what kind of therapy, So in this situation, you require, the patient is fairly bad neurological, so you will require really speech therapy. Doesn't make any sense. No, when you understand her name, you will talk about physiotherapy to get her to achieve some sort of motor milestones. You'll try to give occupation therapy, which will help her to use her hands, correct? And then later on, we'll see if she improves a lot, we can talk about things like speech therapy and language therapy and all that. But speech and language therapy would be useful in a young child like this if there was feeding problems. So even if he's very delayed and there's a problem of feeding and chewing and swallowing, then these exercises, oromotor exercises, etc., can be done to help that. What about your counseling the parents? Because the parents have come to you for two things. Is there any specific treatment? And that is something which you have to tell them nicely over a period of time that there may not be anything of that sort, but you must emphasize the physiotherapy and all these therapy things. And then when they ask you, will my baby walk or not walk? How will you say? Will my baby talk or not? What will you tell them?
As I explained that this is the child is comparatively slow and back compared to other children. Since the child has not achieved sitting and now the child is 4.5.
In simple language, what will you tell them?
Because your child has not achieved sitting yet, so there is a slight the probability of walking and running is little less from but we should continue for the physiotherapy and other occupational therapy. The child might get improve a little, if not like the other peers, he might still improve from the current situation.
Okay, I mean, I would be a little more gentler than that. Over a period of time, you should tell her this. You should first give her positive feedback that what are the positive things in the child. See, there is some improvement. There was no head control. Now there is some head control. There was no sitting. Now there is some sitting. I think we'll use, we don't know the cause as yet, but therapy would help a lot. And therapy will help him to achieve more milestones. And we'll see. And over a period of time, you explain to them. They ask you, no, chalega ke nahi chalega. I see, we're not sure as yet. You haven't started any therapy. So we'll see over a period of time. And then over a period of 2-3 times, then they'll also understand, and you also give that message. But the first day, there's no point in telling them, because as soon as you tell them that, they will not do anything. You understand? So I think learn how to counsel. Don't just, you're right. So actual counseling, if you were in America, you would probably say, they see your child has got no chance of walking. Not yet sitting at 4.5 years, so there's no chance of walking in this and that and the other. That will not, work in our part of the world. You have to be a little gentle, but over a period of time, this thing should sink in that there is an issue. And the other important thing is we should do the genetic testing. So over there also, you tell them about prenatal diagnosis. And suppose you decide later, to have a kid or something, you must know that this shouldn't happen again. That's what I'm saying. Okay, chalo. Rajesh, anything else? Sorry, 8 o'clock.
I think that's it. Thank you very much, Dr. Udani, for that excellent 2-hour session. And I'm sure all the students benefited both in the writing of the theory part and this case. And we'll have many more such sessions. The only thing is students have to speak up. That is the only way to learn. So more and more of you have to come forward to discuss, and it's good that some of you have volunteered.
I think
to come
one
forward
suggestion I have that you should have 3-4 people. Suppose one person takes the case, there should be at least 3-4 people who can discuss that case. So even if they haven't seen it, they can see the case from, and discuss, so that we have more than just one voice in the case.
Absolutely. In fact, the discussants were meant to be for both parts of the class, but somehow they kind of disappeared. But let's hope next time they'll stay till the end.
Okay.
Thank you very much, everyone. Thank you, Dr. Udani, sir. Thank you.
Thank you.
Thank you, sir.
Thank you, sir.
Bye-bye.